fill out the forms for that. The bathrooms are just out to the right here. We will have a couple of breaks during the day, a half hour for lunch for you to enjoy the beautiful environs here. And I think with that, you should settle in, have a great day. Take your own breaks if you need to go grab some food. And with that, I don't see Chet Hewitt here quite yet. So I am a little puzzled by that. But Carla, do you know anything about where Chet may be? He's here? Okay, good. So any logistical questions before we get started? If people could mute their phones, we'd appreciate it. And if there are stragglers out the door, if somebody could round them up and get the group started, that would be great. So let's see, just a little bit more orientation while we wait for the president of Sierra Health Foundation to enter the room. Chet Hewitt has been a wonderful supporter of the Right Care initiative and the whole Sierra Health Foundation since we started here in July 2012. We have been meeting with the Capital Region Right Care University Best Practices on the second Monday of every month in this room. In San Diego, they meet at UC San Diego on the first Monday of the month, sharing best practices. And in Los Angeles, as of now, it's the last Friday of the month, and we're polling people about whether we need to change that date slightly. So just to let you know where people are in the room, we have, this is our researchers table here, if you all want to consult with them. Dr. Lindsay, are you able to, so we have you up at this table here, and Arnie, can you join us at the head table? Arnie Milstein from Stanford. So let's see, we have a wonderful award ceremony or reception from 4:30 to 5:30 out on the deck here. It is going to be an absolutely gorgeous sunset with a supermoon happening today that I think if everybody's seen it in the press, it's supposed to be one of the largest moon risings that we have experienced in our lifetimes. And I think what we might do actually, since Dr. Chet Hewitt appears to be delayed, is go ahead with LaVonna, if you could join us, and then we'll trade places with Chet, because we have a tight agenda and we're running a few minutes over with our first speaker. Thank you so much. Professor LaVonna Blair-Lewis is our Right Care host in Los Angeles. She's been a Right Care enthusiast since, I don't know, she's been helping with the Right Care initiative since about 2008, and supplying students from the University of Southern California, etc. And she is going to regale us with some wonderful data and enthusiasm for the importance of this work. Thank you, LaVonna.
Thank you, Hattie. And I want to start by actually thanking Hattie for being a tireless champion for moving the needle as relates to quality in the state of California. She has been working behind the scenes, in front of the scenes, every place she had an opportunity, and again, we honor you and the work that you're doing. And so I'm starting with a call of action because the reality is there is for me a personal urgency to the topic. I've been dealing with cardiovascular disease and diabetes in local communities since 1999. And the reality is that we've had a tectonic shift post the election. There are very real questions about what's going to happen next. What's going to happen with those 20 million people who are no longer, are going to have a different type of health coverage. And disparities existed before that reality. And so this call to action is for me more than a side gig. It is something that's critical, and I'm hoping that it is as important to you as it is to me. And so here's basically one of the reasons why. The reality is that demographics nationwide continue to change. This is again 1970 to 2010. And again, to recognize that, you know, the demographics are changing. This is just kind of one representation around race and ethnicity, but there are other differences around gender, differences around age. The reason why I call this kind of the dangers of kind of reporting all is that some of those differences get lost when we kind of mask them with a kind of an all-population mindset. And so in addition to, again, these types of differences that I've already mentioned, there are also geographic differences. And this is looking at 2010 and 2012. And really what you're looking at, those places around the country, dark blue, which have become more diverse, and those places light blue, which have become less diverse in the last 2 years. And what is very, very clear is that the majority of the country has become more diverse. And so the reality is that diversity is real unless we take some very aggressive stance in terms of changing those numbers. Again, that's what we will continue to see. And so those differences by geography are critical, but then there's also these differences by community. And recognizing that all the research is telling us now, as we look at the social determinants of health and look at the importance of place-based strategies and interventions, that my community influences my health. And so clearly there's a list of things that make good health more likely and things that make poor health more likely. And again, those differences in place leading to disparities as relates to diabetes, cancer, asthma, other obesity, injury. Heart disease isn't there, but clearly it should be, and that's kind of what we're talking about. So going from the community to this issue of what's going on nationally. And the Agency for Healthcare Research and Quality has two responsibilities. It tells us how we're doing as it relates to addressing the issues of quality and issues of health disparities. And what you'll see in these graphs from 2016 are the issues in terms of the indicators that we're collecting at a national level that clearly demonstrate that high and low income residents have poor health. And when you look at those differences, again, within not just looking at all, but looking at particular population groups, you can see that number one, we don't have all indicators for all groups. So sometimes we haven't been able to collect the data for some of these subpopulations, and it's showing up at the national level. And so again, what you'll see, the green means that things are getting worse. Blue means that things are getting about the same. And black means that things are getting better. And what you'll see is that as you look across the scales, that the majority of things are at the very highest level. Things are remaining the same, and in some instances, they're actually getting worse. And again, this is before, again, moving back to maybe people having even less coverage and their access kind of going forward. So access to care, again, is critical. So why should we even care about this issue of access? Why should we care about health disparities? The reality is that health disparities are costly. A report came out in 2009 which basically said if the health status of African Americans, Latinos, and Asian Pacific Islanders was the same as the Anglo population from 2003 to 2006, we would have had approximately $230 billion that we could have done something else with. If you add non-health related costs, things like worker productivity, premature death, the number goes up to roughly $1 trillion. And so what could we do with that money if it was on the table? But again, it's not on the table because health disparities exist. And so again, part of what we're doing is trying to address the health disparities. So that brings me to the kind of the local call to action, if you will, the statewide call to action. And again, this is about the danger of all. So at the far right, you see California. What is the rate of myocardial infarction in 2014 for the state of California? So we get one number, but clearly when you look across the different population groups, the numbers are radically different. Whites are different than blacks, Hispanics, Asian Pacific Islanders, and Native Americans. And so again, we can take an all mentality, but again, the bottom line is that that's costly because we miss significant differences. And so obviously, since you can see that African Americans are the larger category, that's what's going to be blown up for the next few slides. And so this is looking at the University of Best Practices team. So you have, again, State of California, then you have California Blacks, then you have San Diego, Sacramento, and Los Angeles. And so even within the African American population, geographic differences persist. And so we can ignore these differences and continue business as usual, but the reality is these numbers are not the figment of someone's imagination. They're real. They have not just kind of quality of life consequences, they really literally have life and death consequences. And we're here today because we're concerned about the long-term effects of those kind of disconnects. Same thing with strokes. And again, looking at California, you can see that we have one rate when we look at the state of California, but again, when we go into deeper dive into those individual categories, those population groups, you know, what difference does it make? Clearly, there are differences, and again, the same thing is true when we look at strokes by geography, San Diego, Sacramento, and Los Angeles. So again, for me, the call to action is that, you know, do we believe that our quest for quality improvements, better outcomes, value-based healthcare changes with the new administration, or is it something that we're committed to, not just because they've been mandated, because they're fundamentally the right thing to do? And so that's kind of my question to the group. And this is kind of my first question. You got a polling opportunity on you got your clickers, and so hopefully, question number 1 says, what contributes to the variation that you have just seen in the rates of stroke, myocardial infarction, and your responses are differing responses to medication and access to appropriate care, environmental factors and opportunities for healthy exercise, cultural, dietary preferences and food availability, genetics, or E, all of the above. Please take some time to look.
We have 64 responses, not bad.
Okay, so should we close the poll? All right, so, yay, the majority of us knew. And why is our answer to this question important? The reality is, it makes it clear that there is no magic bullet. There is no one entity or organization that's going to move the needle. It is a collaborative enterprise, and so the health plans and the medical groups and everybody else in this room that's trying to move the needle needs to understand that if I'm really going to see the differences that I want to see, I've got to mobilize multiple sectors to do this. The reason why I'm here is that because I've always been connected to the community, the people that are kind of at the grassroots. And so helping to engage them in some of these topics so that providers will know that they're not just, when they're not following recommendations for care, it's not necessarily that they want to be dismissive of clinical recommendations or clinical ideas, but the reality is following those instructions are more difficult in some communities than others, and this makes that very clear, right? It's like, what do I know about the context and where people are spending their time that may be influencing their adoption of best practices or medical kind of expectations? So again, it is all of the above, and so that means that everybody in the room has a chance to get involved. Albert Einstein said we cannot solve the problems we have created with the same thinking that created them. He got credit for being a pretty smart guy, and so hopefully we will recognize that, again, business as usual, the time has passed. And so this is my second question for you, and it doesn't, it's not going to come on a clicker. This is more a question for personal reflection and kind of personal engagement. In some of the kind of management literature, we talk about what's your wow. What is it that you're willing to do within 1 week that will improve health outcomes for diabetes and heart disease? There's going to be there's going to be quite a bit of information in terms of what people are doing on the ground right now. Is there one thing that you think is kind of critical to maybe fast track some of the work that you're trying to get in your particular geography? Again, I wish there was a magic bullet. There isn't. It's going to require all hands on deck, and luckily we've got a full room and a good start. So thank you for your time, and thank you for your work.
Morning, I'm Steph Bertol.